Yeah, very good evening to all of you. So I welcome you all for this further next episode of Young Surgeon Forum. This we are having almost 18th episode from the beginning. We have done lot many episodes with many esteemed institutions all across India like AIMS, Ganga Hospital, even Miraj Hospital, and they were very successful. And along with MOA collaboration with the idea of Dr. Wasudeo Gadegone, who is the MOA president, we are further taking it ahead. So I welcome you all for this episode, and the topic for today's episode are about posterior acetabular injuries, general orthopedician's perspective. So for this, we do have Dr. Wasudeo Gadegone as MOA President and Dr. Karne as MOA Secretary. The convener for today's episode is Dr. Nitin Kimmatkar. The moderator for today's session is Dr. Pradeep Kothadiya from Solapur. The panelist for today will be Dr. Nirbhay Karandikar, and I will be coordinating session along with Dr. Pradeep Kothadiya and Dr. Kimmatkar. And we do have eminent faculties from across Maharashtra. Dr. Venugopal Sambharam, who is from Solapur, who has done his MBBS and DNB from Solapur. He is currently practicing at Sambharam Nursing Home, as well as he is attached to Solapur Sahakari Rugnalaya and Research Center at Solapur. He has a keen interest in trauma, orthoplasty, arthroscopy, and pelvic injuries. The second faculty or speaker for today's session is Dr. Milind Joshi. He has also done his MS from Solapur, and he has done prestigious fellowship with Dr. Milind Chaudhary Nilizara at Akola. He is currently working as AP at Ashwini Kumbhari Rural Medical College, Solapur. He is also running his own hospital as Ashwini Rugnalaya and Sushrut Clinic. And he has keen interest in various trauma topics like non-unions, arthroscopy, orthoplasty, and even pelvic acetabular injuries. The third speaker for today will be Dr. Vijayananda Lokhande. He is from Pune. He is a consultant trauma orthoscopy and joint replacement surgeon attached at Sahyadri Hospital. He has done various fellowships with Dr. Sachin Tapasvi at Pune, Dr. Sanjay Agarwal at Mumbai, and also done CCOT fellowship awardee at Pavia, Italy. He has a keen special interest in complex limb and pelvic injuries and adult hip and knee joint surgeries. The fourth speaker today will be Dr. Aditya Kekatpure. He has done his DORTH and DNP from Mumbai. He is an ECF MG certified from USA and is currently working as AP at Department of Orthopaedics at Savangi, Varda. He has done his adult reconstruction fellowship from Seoul, South Korea. And again, his area of interest are the pelvic injuries and adult reconstruction. So I must thank Dr. Pradeep Kothadiya, who has made this beautiful program of around 120 minutes. We'll be having two cases. This is the brief outline of the program which we are going to have today. So without wasting much further time, I will like to have a few words from Dr. Wasudeo Gadegone sir to welcome all the faculties, and then I will ask Dr. Pradeep Kothadiya to take over.
So welcome all from the Maharashtra Orthopaedic, greetings from Maharashtra Orthopaedic Association. This is Young Surgeon Forum. We are conducting webinars on each and every Saturday. Dr. Manoj Pahukar is a coordinator. Today's webinar is moderated by my elder brother, Dr. Pradeep Kothadiya. There are distinguished faculties from all over Maharashtra. They are joining here and deliberating their experience on posterior wall pelvic injuries. I hope this message will go to all new younger generation how to deal with the posterior wall fractures. Welcome to all delegates of OrthoTV as well as all members of Maharashtra Orthopaedic Association. And I thank very much to all faculties who will going to give their and spread their knowledge amongst us. Thank you very much.
Thank you, Dr. Gadegone, for introduction, as well as Manoj introducing the faculties. Dear friends, pelvic injuries, when I was a student, was a neglected topic. It was absolutely a topic in the option. And what we used to do those days is only just to give traction and just try to give a lateral traction or a vertical straight traction and treat these injuries. And we used to get very bad results, and we used to get much arthritic hips those. But now with the things with this high velocity trauma, the number of incidents of these injuries are increasing. And even we are also getting into these injuries, making them understand very well. This topic today we have selected for a general orthopedic surgeon. I feel any orthopedic surgeon in Maharashtra should be able to tackle these injuries, mainly the posterior injuries, because they are the most common injuries we come across. So with this introduction, I would like to start the first case. Is a 28-year male who has a road traffic accident. The screen is not visible? Yeah. The 28-year male with alleged history of road traffic accident, hemodynamically stable, nil neurological dystally, hematological parameters are normal, and this is his X-ray of the patient. Now I call upon Dr. Sambharam just to give an idea how to read these X-rays, how to see the CT scan, and how to classify these fractures. So I request Dr. Sambharam just to take over and start telling us how to read this X-ray.
Am I visible, sir?
Yeah, you can start.
Good evening, everybody. First, I would like to thank Dr. Gadegone, sir, Karne, sir, Pradeep, Kothadiya, sir, Nitin, sir, and Manoj, sir, for giving me opportunity to present, for giving a opportunity for presentation. My topic is reading of X-rays and the CT scan. For diagnosing the acetabular injuries, the X-rays which you need are AP view, Judet views. These are iliac oblique view and the obturator oblique view. And along with this, we need a CT scan in which 2D plus 3D reconstruction films are necessary. This is an oblique view in which the injured hip is touching to the table and the iliac blade is perpendicular. So you get a view like this. In this iliac oblique view, what we see is the posterior column, anterior wall, and whole of the iliac blade. In the obturator oblique view, the radiographic beam is roughly 90 degrees to the obturator foramen, and the injured hip is upside with the normal hip near to the table. And what we get is the anterior column line and the posterior wall line. So these are basic X-rays, oblique X-ray, Judet views. And now we see a routine standard AP X-ray. What we see in AP X-ray, there are various lines. We'll see in detail. The first line is called as iliopectineal line. It is nothing but the anterior column line. Ilioischial line, which is nothing but a posterior column line. Third is the medial wall and the teardrop, which is displaced medially and damaged if the quadrilateral plate is damaged. And the weight-bearing dome, which is a very important portion. If this is damaged, the patient will land up with early OA of the hip. And then next is the anterior wall, which runs from the superior lateral aspect of the hip joint, running to the inferior margin of the superior pubic ramus. And next is the posterior wall line, which runs from the superior lateral angle of the acetabulum to the ischium. The last is very important, obturator foramen. So these lines will be repeating now on and off, which help in us in diagnosing the fracture. The findings in CT scan, what we note here, we see the joint congruence when there is a posterior dislocation along with fracture of the posterior wall. We see that normal hip is congruent, whereas in the injured, it is incongruent. In the next, we sometimes see along with dislocation, the femoral head is touching and we get a marginal impaction. Then the next, you can have sometimes the loose pieces of the wall lying inside the joint, which can be very well assessed in 2D cuts only. And again, this is the femoral head fracture, which are very well visualized in the 2D cuts. What we see in the 3D CT cuts are, it helps to define the combination and the fragment rotation. It can be rotated in any plane to produce the real-time sequence image, and it is necessary for preoperative planning and implant fixation planning. Also, the femoral head subtraction views, which we get an image as if we are removing the femoral head and we are seeing the joint from inside. So this is a femoral subtraction view. Now the femoral head is removed. You can note the joint from the inside, and we get images also, all stamp size images from all views. And this is what I told you, a real-time sequence imaging, where we can literally rotate the pelvis and see, which helps us to have an approach where the fragments are and what type of fixation we can give best to the patient. Now, Luternal and Judet have classified acetabular injuries as elementary fractures, which are also called as simple or pure fractures. I remember my teacher Pradeep Kothadiya telling that these simple fractures means the fracture is in one plane. Either it is in the vertical plane or a horizontal plane. Thus, in these simple forms, you get either a posterior wall, posterior column, anterior wall, anterior column, and a transverse fracture. And the next are associated fractures, which include the posterior column and the wall, anterior column and wall, or anterior with posterior hemitransverse, or transverse fracture with posterior wall, T-shaped fracture, and both columns. Thus, these fractures can also be described as complex fractures. This is how a classical posterior wall fracture looks like. This is the fragments of the posterior wall, as we are seeing, lying at the superior lateral margin, along with dislocation of the hip. This is classical of posterior column fracture, where ilioischial line is broken off. This is the CT scan image of an anterior wall fracture. You can note here the anterior wall fracture is seen. This is an anterior column fracture where iliopectineal line is broken in the obturator oblique view. This is a transverse fracture where both lines are broken, but you can see the obturator foramen is intact. This is a classical X-ray of posterior column with wall, posterior column and a wall fracture. This is T-type fracture. Both lines are disturbed, and also there is a fracture of the obturator foramen. Thus, it forms a T-shaped fracture. This is the anterior column with posterior hemitransverse. We get iliopectineal line is broken and ilioischial line is broken. Both lines are broken, and we get a gull sign, which is classical of this because the femoral head impinges against the anterior column, and we get the marginal impaction of the anterior column. This is what that is seen. The next and the last is bicolon fracture. This is the X-ray where the acetabulum is totally floating and it is not attached to the parent axial component, and the remaining axial component bone forms a spike which is seen as the spur sign. This is best seen in the obturator oblique view, and this is the diagnostic of the bicolumnar fracture. Thus, these lines now help us to differentiate and diagnose various fractures. Now we'll see how these fractures are classified depending upon these lines. The first line, if we draw iliopectineal line, if that is intact, then something has happened posteriorly. That means posterior wall, posterior column, or column with wall is fractured. And if it is broken, the other 7 types will be seen: wall, column, transverse, T-shape, transverse with posterior wall, anterior column with posterior hemitransverse, and bicolumnar. Thus, if the iliopectineal intact, you see for the ilioischial line, if it is intact, posterior wall fracture is there. If it is broken, it can be posterior column or posterior column with wall. Now coming again below, if the iliopectineal is broken, there can be 7 types. Now, if you trace out the ilioischial line, if it is intact, anterior wall or column is injured. If it is broken, it can be either a transverse with posterior column, T-shaped or ACPHT, and bicolumnar. And further going, if the iliopectineal is broken, both are broken, that means we are coming down to transverse with posterior column, T-shaped, ACPHT or bicolumnar. Now you have to see the obturator ring. If it is broken and a spur sign is seen, it is a bicolumnar. Spur sign is not seen, it can be T-shaped or ACPHT. If the ring is intact, it can be transverse or transverse with posterior wall. Thus, all these fractures can be classified with the help of all these 4 lines: iliopectineal line, ilioischial line, obturator ring sign, and spur sign. Now we'll take few examples. This is the X-ray. Before I come to all drawing of these lines, I give a view that these are all the 10 fractures. Out of these, the first 2 are the pure anterior column varieties. 3rd and 4th are the pure posterior column varieties. And from here starts the, excluding transverse, these are all the complex fractures. Here, if you see transverse and transverse with posterior obturator ring is intact, but rest all obturator ring is broken. So now in this X-ray coming, if we draw iliopectineal line, it is intact, means the pure anterior form is gone. If you draw iliopectineal line, the posterior column is gone. Now, if you see, both lines are intact. Here transverse and transverse with posterior line, they are broken. So these two will be gone and the obturator foramen is intact. So all will be gone. Now only remaining is the posterior wall. If you see, if you take a obturator oblique, here the posterior wall line is broken and a piece is lying there. Thus, it is a posterior wall fracture. The next X-ray where you draw iliopectineal line and pure anterior forms are gone. Ilioischial line, something is happening posteriorly. Now, if in the transverse and the transverse posterior, both lines should be broken, but here one is broken. Means these two can be excluded, and now you draw the obturator foramen, it is intact. Means here in this complex, obturator ring should be broken, so these will go away. Now, if you draw a posterior wall line, it is intact. Obturator oblique also shows a posterior wall line intact, means the posterior wall is gone off. Thus, it is a case of posterior column fracture, which was confirmed by a CT scan, the posterior column fracture. Next case here, we draw iliopectineal line, it is broken. Ilioischial line is intact. So pure posterior forms are gone because of the ilioischial line is intact, pure posterior forms are gone. Then the out of two lines should be broken, one line is intact, thus transverse with posterior wall is gone. Now draw the obturator foramen, it is intact. So all these four forms are gone. Now remaining is anterior column and anterior wall. When we take a iliac oblique view, here we see the anterior wall is intact. Thus anterior wall fracture is gone. It is a case of an anterior column fracture. Next case, here iliopectineal line is drawn, that is cut off. Ilioischial line, that is cut off, means pure forms are gone. Then you see the obturator ring, it is intact. Then you take an obturator oblique, there is no spur sign. Thus, all the obturator ring is broken in all these forms. So these four go away. Then no wall fragments are seen. If the wall fragments are seen, that fits in transverse with posterior wall. Thus, it is a case of a transverse fracture. This here, both lines are broken. Something is happening in both sides. So pure forms are gone out. Obturator ring is broken. Means here transverse, the ring should be intact. Transverse with posterior, these two are gone off now. The remaining obturator oblique, when you take, there is a spur sign seen, that what we have described. Thus, bicolumnar fracture. This is the diagnostic of the bicolumnar. If you see a spur sign in obturator oblique, it is the case of a bicolumnar. This is how we have diagnosed. The CT scan again confirmed acetabulum is totally floating, and this part of the iliac blade is attached to the axial skeleton. This is the last X-ray. What sir had shown us to prior. Here, iliopectineal intact. That means pure form anterior is gone. Ilioischial line, pure posterior forms are gone. A posterior column is gone, and the obturator ring is intact. So all these will go away. Now, if you draw a posterior wall line, it is broken, and there is a piece lying above and superior laterally. Thus, it should be diagnosed as a posterior wall fracture with dislocation possible. Thank you. This is how we can diagnose all the fractures with the help of the simple lines.
Thank you, Dr. Sambharam, for giving us an idea how to read the X-ray, CT scan, and how to classify the fractures. Now, I will ask Dr. Aditya. Now, you have seen the X-ray, you have seen the patient has got dislocation. So, what you will do? What is your next step? You have diagnosed it, you have seen the, and now what is your next step? Dr. Aditya?
Yes, sir. So, my screen is visible?
Yes.
Good evening, sir, and greetings on the occasion of Gudi Padwa, and special thanks to Maharashtra Orthopaedic Association for giving this opportunity. So, sir, the next step will be once the diagnosis is confirmed based on radiological examination, and I will go ahead with emergency reduction, and once reduction is done, then I will check for stability. So, the objectives of my talk will be to discuss the reduction techniques. Once we have radiologically diagnosed, it is a case of posterior dislocation of the hip. And once we have reduced it, and how to check for hip stability, both clinically and radiologically. So before we go ahead, patient evaluation is most important. So primary screening. So always we remember that life saving is important than limbs and then followed by limb saving. So being a high velocity injury, abdominal and chest injury has to be ruled out. Once the patient is hemodynamically stabilized and the neurovascular examination is normal, and then we go ahead with the radiological imaging, which has been very beautifully covered by Venugopal sir. So once the confirmation of diagnosis is there, the attitude of the limb will be in flexion, adduction and interrotation, and the radiograph will be demonstrating an injury as already shown. So reduction should be performed as early as possible, and the influence of reduction in relation to injury time and the development of femoral head necrosis is still unclear. However, whenever it is a pure hip dislocation, the 6-hour rule seems to be logical. So emergency reduction. So what we do, we give one single attempt of close reduction in emergency department. If it is unsuccessful, then we plan for general anesthesia to avoid further damage to the cartilaginous structures. So how to reduce? There are various reduction maneuvers for reduction of posterior dislocation of femoral head. It can be a Ali's maneuver, a Bigelow's maneuver, Captain Morgan technique, Leftovitz maneuver, East Baltimore lift, Howard maneuver, or piggyback method. But considering all this, it becomes difficult to decide one. Go ahead with one thing which works best for you. So the Ali's maneuver is performed by giving an axial pull in a supine position with the hip in 90-degree hip flexion, hip and knee in 90-degree flexion with a counter pressure on the pelvis and slight rotational maneuvers. The Bigelow maneuver is comparable to the Ali's technique with the leg additionally held in maximum adduction position. So I'll just demonstrate. The video is not playing. Just a minute, sir. So this is the similar case which I have shown. So in this case, we had given spinal anesthesia. You can see over here, the assistant is is balancing the pelvis. Now we get an assistant on the contralateral side. We use the shoulder of the assistant, and it is used to apply inline traction to reduce the femoral head. So once the femoral head is reduced, we check for stability. We first of all check for rotationals with giving with the hip in flexion, and this is confirmed fluoroscopically. So when to go ahead with open reduction? Like in previous video, you could have seen that we had kept the trolley ready. In case our closed reduction would have been unsuccessful, we would have definitely opted for open reduction. So whenever we have inability to reduce the hip with closed method, a non-concentric reduction, or if there is a fracture fragment within the articulating surface of the hip, or if there is an associated injury, in these cases, I will definitely go ahead with open reduction. So how to check for stability once we have got a reduction of posteriorly dislocated hip? So the criteria for hip stability, the hip is considered to be unstable if there is a clinical hip instability demonstrated at 90-degree hip flexion with 0-degree adduction and 0-degree rotation. There is redislocation after successful closed reduction, and radiographic criteria is a subluxed femoral head on radiograph. A difference of 0.5 mm as compared to normal side is considered significant. And also if there is a displaced posterior fragment and a percentage of the remaining intact posterior acetabulum. I'll come back to this. What do we mean by acetabular fracture index? So the hip joint stability depends, the posterior stable hip depends on the adequate posterior acetabular coverage of the femoral head. Unstable posterior fracture dislocation of the hip is created by posterior acetabular wall fractures. So in general, a posterior wall fractures that involve more than 40% of the posterior wall will be unstable, and those that involve less than 20% will be stable. So as recommended by Larson, axial femoral pressure in 30 to 40 degrees of flexion with a axially directed force. If the femoral head redislocates, it is considered to be an unstable situation. Now coming to dynamic stress fluoroscopy. This is considered as optimal test for stability, and because it gives a direct visualization of the hip under physiological stress. So how it is done? With the limb in full extension and neutral rotation of the hip joint, we carefully flex the hip to 90 degrees and give slight axial pressure along the femoral shaft axis. We check for the congruence of the hip joint on the pelvic AP and obturator oblique view. If the hip joint remains congruent, examination is additionally performed in 20 degree of adduction and 20 degree of internal rotation. Every subluxation of the or hip joint incongruence is considered to be unstable. Now, what are the radiological determinants? Now, these are the radiological determinants based on CT. There is a, now it is proved that CT scan has a definitive role in diagnosing instability of the femoral head. So what we see for subluxation of the femoral head, we see for the remaining intact posterior acetabular arch, and we see for the we measure the fracture displacement. So if the defect is more than 50% and the acetabular fracture index is less than 34%, it is an unstable hip. On the other hand, if the defect is less than 20% and the acetabular fracture index is more than 55%, it is a stable hip. So how do we do that? So on an axial cut, we measure, like in this pictorial, you can see acetabular fracture index is determined by measuring the alpha angle on the fracture side as compared to the normal side. And as in the last slide we have discussed, whenever the AFI is less than 34, it is an unstable hip. Now this paper has come up and it shows that there is a definitive role of intraoperative CT scan in the assessment of posterior wall fracture acetabular fracture stability. So like this is a intraoperative CT scan showing a static view, a dynamic stress view, and a dynamic stress view at 45 degrees. So this is a stable hip. There is no incongruency of the femoral head. So this paper concluded that intraoperative ISO CT imaging improves the surgeon ability to assess intraoperative stability of the posterior wall fractures during stress examination as compared to standard fluoroscopic images. But this is not routinely available in all centers. So finally, coming back to this, can experts in acetabular fracture care determine hip stability after posterior wall fracture just using pain radiographs? So this paper has concluded that whenever we are in the gray zone of 20 to 50% of the acetabular wall involvement, so when in doubt, go ahead with open reduction and internal fixation because it is much better. So, and also it concluded that examination under anesthesia should be considered as a useful addition to the surgeon's armamentarium in determining hip stability. Thank you for your kind attention.
Thank you, Aditya. Aditya, I would like to ask you.
Yes, sir.
When you like to do a CT scan, pre-reduction or post-reduction?
So when the patient comes to me and I'll first of all do a X-ray, once my diagnosis is confirmed, I'll go ahead with one attempt of closed reduction.
Okay, so you will do the CT scan after reduction?
Yes, sir.
Not before reduction?
Yes, sir.
Okay. Thanks, Dr. Aditya. We have given explanation very well of what is the test of stability. Now we are dealing with unstable hip. The hip is not reducible. It's not there. As you have shown that you have kept the surgical things ready when the hip is irreducible. So now we are going to open the hip. And now I request Dr. Nitin just to tell us how we are going to proceed further, what approach we are going to take to reduce these fractures.
Good evening, everybody. I'm Dr. Nitin Kimmatkar. Whenever the hip is not reduced or not stable after we have seen the posterior wall fracture dislocation of the hip, we can go in for an open reduction of this hip. There are the approach commonly we use is Cocker-Langenberg approach. It can be done in prone position also and in lateral position also. Most of us are well versed in the lateral position. The indications of Cocker-Langenbach approach is isolated posterior wall fracture, posterior column fractures, transverse fractures, T-shaped fractures, which are infratectal or juxtatectal variety associated with the posterior wall involvement. In the lateral position, whenever we are seeing this patient, now this is a position of the patient. This is anterior aspect, this is posterior aspect, this is superior head end, and this is the foot end of the patient. We generally mark the greater trochanter, we generally mark the posterior superior iliac spine, and we generally mark the midpoint of the shaft of the femur. And around 3 to 4 fingers below the PSIS, we start a curvilinear incision, which is centered on the greater trochanter along the shaft of the femur. Then skin and soft tissues are generally dissected out, as it will be seen in this video. The timing of the surgery is generally from if it is an urgent thing, if hip is not reducible, then it is urgent, and if it is reduced hip is there, then you can proceed from 2nd to 5th day, or whenever as early as possible. So skin and subcutaneous tissues are incised, then you go in for an fascia lata incision on the thigh, on the femur, which is again confluent with the gluteal fascia upwards. And in line of the skin incision, you divide this fascia, and downwards you can see the facial fibers, and you can see vastus lateralis muscle, and above, when gluteal fascia is confluent with the gluteal muscle, gluteus maximus muscle is seen, and this muscle is separated till you see inferior epigastric arteries as well as nerve. This you should take care that this inferior epigastric artery as well as nerve should not be injured, because this supplies the gluteus maximus muscle, and there is a fear that gluteus maximus muscle will go in for an ischemic necrosis. So after putting on this channel retractor, you can see that there is a there is a trochanteric bursa is there, which is attached to the trochanter. You can gently dissect this bursa. If the injury is mild, you can see that every structure could be cleanly seen. To expose to increase the exposure, you can incise the gluteus maximus insertion on the linea aspiria, so that there should be some tissue remnant should be left of about 0.5 centimeter, so that further whenever you go in for a closure, then you should be able to close it. There is always a bleeder associated in that Gmax insertion of the linea aspera. You should be able to cauterize it very cleanly, and then you proceed further. Many times in the devastating injury, after this step, you might not see thing in the proper order. There could be severe soft tissue contusions, and everything would have been torn off. So in the clean cases, you could dissect out this trochanteric bursa. Underlying this, there could be, you could see anatomy as regards to gluteus medius muscle, then piriformis muscle, then there could be obturator internus muscle along with the gamellae, and quadratus femoris muscle. Initially, over the quadratus femoris, you should identify sciatic nerve from the below upwards, because the anatomy at the quadratus femoris part is very well maintained whenever there is an hip dislocation as well as posterior wall fractures. Now we are separating one interval of gluteus medius muscle on the gluteus minimus muscle, and you can put in a cobra retractor or curved human inside it so as to increase the exposure. This will clearly show you the piriformis muscle, which is coming from the greater sciatic knot and inserting on the trochanter. You should take a tack sutures of this piriformis muscle, so that and it should also be divided around centimeter away from the insertion, so that whenever you are coming, whenever you are closing this thing, you should be able to close this piriformis muscles properly. Downwards, you could see the quadratus femoris muscles also. And, you should also identify obturator internus muscle, which is coming from the lesser sciatic notch. And this anatomy is very important because we need to find out the greater sciatic notch also and lesser sciatic notch. So sciatic nerve and piriformis muscle will guide us to the greater sciatic notch as we bluntly dissect these structures above, so that we are not confused in the local anatomy. As we also see that this tooth forceps is telling us the medial circumflex femoral arteries root, and it is below this obturator internus muscle as well as gamellae, and it comes from the quadratus femoris, go underneath, and it is lying just flush to the bone. So the tissue should be at least 1 centimeter away. Your cut of obturator internus as well as gamellae should be around 1 centimeter away from this, so as not to disturb the blood supply to the femoral head. So that has an positive implication in the avascular necrosis of the femoral head. Many times such type of dissection is not possible. You have a great separated fragment of the posterior wall. So if there is a large fragment of a posterior wall, then you can go through that fracture fragment into the hip joint and clean the joint, then clean all soft tissue debris, and then you can reapply that fracture. If it is an isolated single fragment, you can re-reduce it and then go in for further fixation. Now the gluteus minimus, after elevating this piriformis as well as the obturator internus muscle, gluteus minimus is elevated from the hip joint capsule, and cobra retractor is placed under it so as to expose the hip joint on the superior aspect. So now we are protecting the sciatic nerve with the help of piriformis as well as obturator internus muscle. This is surgeon is palpating for the sciatic nerve, and whenever we are retracting this both of these muscles, piriformis as well as obturator internus, then this is protecting this sciatic nerve also. Downwards, after the obturator internus muscle, there is a quadratus femoris muscle which is attached to the ischial tuberosity. So while placing the plate on the ischial tuberosity, you need also to reflect that muscle from the insertional end of ischial tuberosity so as to place the screws as well as plate. So complete eradication of that muscle from the ischial tuberosity should not be done. Only whenever you see a shiny fibers of ischial tuberosity, you should stop the dissection there. So now, whenever the obturator internus muscle is elevated from the posterior column, you are going towards the lesser sciatic notch, and you could see for an ischial spine. Now, surgeon is dissecting on that obturator internus muscle. There is some whitish bursa is there. It is also always there, and you could always identify a clear dissection margin in between the obturator internus as well as the lesser sciatic notch. Now this is the surgeon's finger is pointing to the lesser sciatic notch, and there one retractor is placed in the lesser sciatic notch so as to protect the sciatic nerve, and there is one retractor which is below the gluteus minimus muscle. And now surgeon has cleared the greater sciatic notch with the help of piriformis as well as the sciatic nerve, and there is a clear margin. You can see here that there is a greater sciatic notch margin there. Now whole of the posterior column as well as the posterior wall is in front of you for the clear fixation of the hip joint. So there is also on the superior aspect now, just below this retractor, there is superior gluteal artery as well as nerve, which has been exiting from the greater sciatic notch. You should be able to protect this superior gluteal artery as well as muscle also. And you should prepare some rent or some place for the clear dissection under the sciatic notch so that you can palpate with your index finger towards the quadrilateral plate as well as the anterior column. So after placing this, replacing this retractor, surgeon is trying to place his index finger in the greater sciatic nerve so as to palpate the quadrilateral plate as well as the anterior aspect of the anterior column of the pelvis. So this is an indirect method of confirming your reduction in transverse fracture. So this is very important. So copious lavage should be given after complete fixation of the fracture, and you should fix suture all rotators as well as the G-max muscle, and whatever the contused gluteus minimus muscle should be there, it should be removed while debriding whenever you come back, and so that there are less chances of heterotopic ossification. I thank you for this presentation.
Yeah, thank you, Dr. Kimmatkar, for such a wonderful elaborative presentation. And we could gather all the practical points for doing this approach. Just would like to ask one question. What are the limitations for this approach? Like if you want to expose the more superiorly, if this wall fracture is quite superiorly, would you be able to do with this same approach, or you would modify some?
We need to add an then a trochanteric osteotomy to it so as to go toward the superior aspect of the hip joint, and to get a clear identifiable and reduction, to see the clear reduction of the fracture fragment, we need to add an greater trochanteric osteotomy for this.
Yeah, thank you. And one more question, even like gluteus maximus weak cut. So what is the current role, whether we need to refix it again or to leave it as it is?
No, at least you should be approximating gluteal fascia so as to approximate the rest of the gluteal musculature, so that there is no snapping sound around the hip after you come out of this hip joint.
Yeah. Thank you, Dr. Kimmatkar, for such a wonderful this presentation. So now we move ahead with the further, like we have exposed the fracture, and the most dreaded part. There are some marginal impactions. Then there are few these intra-articular fragments, and then we are stuck as to what we should go further ahead. So for this, now I will invite our moderator and faculty for today, Dr. Pradeep Kothadiya sir, to start sharing his screen, and he will be highlighting how to deal with these marginal impactions in posterior wall fractures.
Thank you, Manoj. I really thank MOA for giving this opportunity. Dear friends, we have exposed the hip. We have done a Cocker-Langen approach, exposed the hip. We have seen the wall fragment. Once you elevate the wall fragment, is it really we see the articular surface facing towards you? No, we don't see any articular surface facing towards you. If after lifting the wall fragment, if you see any part of the articular surface which is facing you, that part you take it consideration that it's a marginal impaction. What is a marginal impaction? Liternal has given the term marginal impaction, or he also calls it a depression fracture. And what he says, he describes it's a rotated, impacted single or multi-fragmentary fracture with depression of the osteochondral fragments into the underlying cancellous bone. It exactly mimics like what we see a depressed tibial condyle fractures. So it's a depression of the articular surface into the subchondral bone. It may be a single fragment or multi-fragmentary. It represents a particular injury pattern which is occurring in conjunction with a pure fracture dislocation or as a part of a complex acetabular fracture. So how we get a marginal impaction? See, a head is getting dislocated. It takes a part of a wall, but sometimes the remaining portion of the articular surface, because of impaction, gets rotated, and you can see that posteriorly this marginal impaction. Displacement of this fracture creates a severe articular incongruity, and if you don't take into consideration this marginal impaction, and if you only try to relocate the articular the posterior wall fragment, then it leads to incongruity. It leads to early degenerative arthritis of the hip. So marginal impaction has to be tackled in a better way. This is the way you get a marginal incongruity. What happens to that fragment? The articular surface, along with the subchondral bone, in the subchondral bone gets rotated at 90 degrees, and that's the way it is facing towards you. So this is the way you get an articular incongruity in these fractures. They have classified this into three types: a superior one, an inferior one, and a middle one. Wherever it depends upon at the time of injury, what is the position of the limb. Depending on that, either you get inferior impactions, sometimes you get middle impaction, sometimes you get a superior infection, sometimes you get both infection. Accordingly, they give a number for this infection. Diagnosis of this margin infection, you can get it on the plain X-rays. In here, you can see this X-ray. See this. This is the way. This is a marginal impaction. You can see the articular congruity of the opposite hip, which is absolutely normal, and you can see this piece which is depressed upwards. So this way, in plain AP view, you can detect the marginal impaction. The best way to detect marginal impaction is a 2D CT scan. Here you can see a beautiful marginal impaction with a wall fragment, and this marginal impaction is very well seen in a 2D CT scan. Even in coronal also CT scan, you see this type of a marginal impaction. So with help of plain X-ray, with the help of 2D CT scan, coronal scans, sagittal scans, you'll be able to know where is the marginal impaction. How we manage this? Always scale approach as we are dealing with posterior injuries. Identify wall fragments, reflect with capsular attachment, joint lavage to clear the debris. Identify the marginal impaction, and what you do? You elevate it using a femoral head as a template. You have to elevate it and turn it towards the femoral head so that you can get an articular congruity very well. Then whatever gap is created after that marginal impaction elevation, that gap has to be filled either with a bone graft or with a bone substitute to prevent the sinking of that impaction. Then reduce the wall fragments and then fix the wall fragments. So here it's a presentation where you can see this is a marginal impacted fragment which is looking at you. This is a femoral head which is on the foot side. This impacted fragment has to be elevated by using a curved osteotome and rotating it towards the femoral head. Femoral head acts as a template. So this is an impacted fragment which is reduced onto the femoral head. And this is a cavity after rotating this fragment toward the femoral head. This cavity is seen in the subchondral bone. It needs to be filled with a graft or substitute. This is a small video which shows us how to reduce the margin fracture. See, with the osteotome, you have to into the cancellous bone. You have to just keep on hammering till you get to the end of this marginal impacted articular fragment. And I'm trying to rotate it toward the femoral head. On your on the right side, this is the femoral head. See the way this marginal impaction has been corrected. It is facing towards now the femoral head. Now the cavity which is there, it has to be filled with either a graft. The graft usually is taken from the greater trochanter. It is a very small graft. If the cavity is too big and the impaction is too big, even you can put some rubber screw and fix this as like a raft screw. Okay. This cavity has to be filled with a graft. Autologous corticocancellous graft, which was harvested from iliac crest, but many times we harvest from trochanter, or a graft, bone graft, or substitutes of hydroxyapatite granules or calcium phosphate cement is used. So here you can see a marginal impaction, which is very well dealt here, rotating this fragment toward the femoral head, and this screw acts as a raft screw, which is going through the hip, which is supporting this marginal impaction. So, dear friends, marginal impaction has to be taken into consideration. You have to treat it when you are doing this surgery. Thank you. Thanks for your patience.
Yeah, thank you, Pradeep sir. I think it was again a very good presentation, surgically demonstrating it. Can you stop sharing your screen, sir? Yeah. So maybe one or two questions for you, sir. Like patient is in the casualty, he has got a fracture dislocation of the hip. You've done a CT scan and you can clearly see there are some marginal impaction or there are some intra-articular elements in the joint. So does still will you like to give a trial for closed reduction or directly you will offer open reduction in that case?
If you see any fragments which is intra-articular, then definitely this reduction will be a chance reduction. It will not be a complete reduction. So in those cases, better to go directly for open reduction and fixation. Now margin impaction, if you detect it, so still sometimes you are definitely try to reduce it. So marginal impaction can be treated at the time of surgery. What is important? Intra-articular fragments, yes, open reduction. Marginal impaction, if you can detect, still you can try for a reduction. There is no problem.
Yeah. Have you encountered any case where there are some intra-articular fragments which we cannot take out and then controlysis happens and patient has some painful hip? Do this
definitely the loose fragments are in the dome area, and if you take out those loose fragments from the dome area, some small fragment of the articles of it, definitely is going to be incongruous hip and it leads to early osteoarthritis of hip.
Yeah. And one more last question. There are sometimes a few bone losses or even the articular cartilage loss, and you will not be able to reconstruct it properly. You are not satisfied. So what do you do at that moment? Like, do you accept with whatever things which are available, try to reconstruct, give the stability?
See, if the fragments are large, you can definitely, now one of our colleague from Ahmedabad, Dr. Pranav Shah, he has taken out all these articular fragments onto the table. Then he has fixed with a 1 millimeter K wires.
Yes, okay.
Those K wires were the lost K wires. And then he has put the fragments back into the position, into the hip. Then he reduced the hip and then he reconstruct the wall. So these are the lost K wires. And he has come. So these things people are doing just to get a very well congruity. But if there are small fragments, it cannot be reconstructed. You cannot do anything. But you can definitely plan that this is going to be not a good hip. It is going to have degeneration early.
Yeah. So yeah, thank you, Dr. Pradeep sir. Now we move ahead for the further. Like we are done with the marginal impactions and now the actual fracture reduction. So may I invite Dr. Vijayananda Lokhande to start sharing his screen, and he will be giving us the tricks for reducing this fracture, temporarily fixing it, and also the concept for the spring plate.
Very good evening to everyone. I would like to thank our President, Dr. Gadegone sir, our Dr. Karne sir, Kothadiya sir for giving this opportunity to present this talk. So I'll be talking on reduction of these fractures and about spring plate. So the spectrum of posterior bone fractures is very big. It is not and never should be considered as a simple fracture. It is the most common type of acetabular injury, but it is the most prone for complications too. So it should be dealt very carefully. So approach is the key for this fracture. It is not always that you just take a Cocker-Langenbeck approach and you can do everything from that. You need to modify your approach according to the fracture, the number of fragments and location of the fracture. So the principles of fixation, we all have our basis from AO. And for us, these fractures are intra-articular fractures. So our motto here is anatomical reduction of the fracture and to achieve absolute stability of the fracture. We do not need a flimsy fixation which may give way small screws or simple K-wire or something. We need a very good rigid stability with absolute stability by lag screws, plus minus by appropriately controlled buttress plates which provide compression across the fracture site. So every point is important. The plate placement, the contouring of plate, position of screws, position of lag screws, everything is important. So once we are open and we need to reduce the fracture, there are some important sequences. First, we need to distract the joint to remove the incarcinated fragments if there are any. So as discussed in previous talk by Dr. Pradeep sir, so I would like to tell here that whenever there is some intra-articular fragments which are encapsulated, we juggle a lot of instruments to remove the encapsulated fragments there. And if we do not need to increase the mobility by dislocating the femoral head, there is a clamp called a Satinsky clamp. It is from cardiovascular side. It has a very big curve. It is not like a mixture of tendon strip or a mixture. It is a very deep clamp by which we can remove the encapsulated fragments without disrupting the femoral head out of the socket or something like that. So we need to reduce the femoral head dislocation. If it is not done by closed means, we need to manage the marginal impaction as suggested by Dr. Kothadiya sir. And then we come to fixation of the posterior wall fragment. And we know that the posterior wall here is attached to the capsule there. So first we can elevate the fracture away from its surface to look for marginal impactions, and then when we reduce it, we first need to reduce it anatomically and fix it temporarily, and then do the definitive fixation. So the sequence starts with traction. So when I started doing these fractures, I started with doing it in lateral position. But now all these posterior injuries I do by prone position, and I think there are very important advantages of doing it in prone position. I would like to just highlight that the most important advantage of doing it in prone position is that your screws or your trajectory of screws is always directed away from the hip joint. By no means they can enter the hip joint. They will always go away from the hip joint if you do it in prone position. The lateral traction, giving lateral traction is very easy in prone position as opposed to lateral position. The palpation of quadrilateral plate in prone position is very easy. Putting anterior column screw through a posterior approach in prone position is much more simpler than doing it in lateral position. Then we need to access the superior part of the posterior wall. Sometimes we do abduction to relax the abductors. That abduction is very easy in prone position as opposed to lateral position. In majority of the posterior wall or posterior column fracture, the gravity itself assists in reduction in prone position as opposed to lateral position. But there are some minor disadvantages. The most important one is that the assistant gets fatigued by holding the retractor and the leg in hip extension and deflection. And the biggest disadvantage people feel here is that you cannot do a trochanteric flip in prone position. So we have to know this before entering. So we start with traction. The traction can be manually with a sham pin placed around the coplanar with the femoral head. We can use a femoral distractor with one pin in the ilium and another in the greater tuberosity or in the trochanteric region. Or some people like to do it in traction table also. Then we need to clean the fracture site. After distraction, the posterior wall is displaced to allow access to the hip joint. The bed is cleaned. We need to preserve as much as capsular and lateral tissue as we can preserve. For reduction, once we have cleaned the fracture, we reduce it temporarily. There are some simple instruments we need. They are like Weber clamps, the picadors or the ball spike pushers, and dental hooks are very important when we have a multi-fragmented posterior wall and we need to reconstruct these small fragments. Once they are brought in place, they are fixed temporarily with K-wires, and definitive fixation is done with a posterior buttress plate or lag screws plus minus, and we can use spring plates also. I will explain it in further slides. So understanding the spring plate. So here we need to understand what do we mean by spring. What people have named it as a spring plate. So spring actually is an elastic device that can be pressed or pulled on a surface, but it returns to its former shape when released, and it is used chiefly to exert constant tension or absorb any movement. So on this definition, we have labeled it as a spring plate. So a spring plate is used to stabilize small articular sided posterior wall fractures, which we cannot access very well with lag screws, or we cannot get them under the primary plate. These spring plates are pre-contoured plates. These are initially they were available only with Synthes, but nowadays all Indian companies have them, the exact copy of Synthes. Or we can modify them with 1/3 tubular plate or reconstruction plates. There are some prerequisites for the spring plates. The hooks are very important for these spring plates. Many people like to use distal radius Ellis plates and other plates without hooks and this region also. But we have to understand that the hooks are important because it provides the second point of fixation. The first point of fixation is provided by the screw, which is going to buttress the plate. And the second point of fixation is by the hooks, which are embedded in the small fragment. So if you do not have the hooks here, it may actually displace or cause shearing forces across the fracture site rather than creating compression there. The plate should be a stiff plate. It should not be very flimsy reconstruction plate. It should be stiff, but it should not be very rigid like a 3.5 plate. And it should be pre-contoured. These plates are over-contoured plates. These are not like our anti-glide plates which are under-contoured. We put a straight plate and put the anti-glide screw and it compresses. It is not like that here. We need a contoured plate here so that tightening of the screw compresses the hooks against the fragment and it creates compression across the fracture site. So this is an example of a posterior wall. We need to, I think, we need to discuss about the associated injuries of this fracture also. This is a case where we can see a posterior fracture dislocation with a large posterior wall fracture. Also, the patient had a avulsion of patellar tendon, he had avulsion of PCL, he had avulsion of lateral collateral ligament along with that. So these are very common because these are dashboard injuries and these injuries usually happen with this posterior fracture dislocation. So as we can see here, there is a large posterior wall fragment with small pieces intra-articularly. So as a simple step, here we can see the femoral head, the articular fragment was flipped and then it was reduced and fixed with the K-marks. Fluoroscopic assessment of reduction is done and then it is fixed with the buttress plate appropriately contoured. We need to bend the plate around the second hole distally and then the rest of the plate need not be contoured because we need an under contoured plate here for posterior wall fixation. For a spring plate, we need an over contoured plate, but for a buttress plate, we need an under contoured plate. And then the fixation was done in AP view, iliac oblique and obturator views. You can see a good reduction of this fracture. And the rest of the fractures were fixed. The PCL was fixed by open views and this percutaneously it was fixed. The patient went on to healing nicely. This is a second example. Again, we can see a very big fragment here. Here we can see sometimes the fragment is so big that we cannot exactly compress it with a single plate. So we need to add two buttress plates there. And post op CT we can see a very good reduction, anatomical reduction here and a congruent joint. And as we say, when there is a superior location of the fracture, as we can see here, with a very small posterior wall, it's not a very big wall. In this case, there comes the role of two things. First, we need to access this area, so we need a trochanteric flip, and to get these small fragments, we need a screw plate. So in this way, these are the three ways: the obturator oblique, the iliac oblique, and the AP view, where a spring plate is used to catch the fragment, and a plate is supplemented posteriorly to buttress the whole wall. We cannot use these spring plates in isolation. Some people do use it for very small fractures, but it is recommended that it should always be supplemented with a posterior buttress plate and they should not be left alone. And it was done with a trochanterically posteriotomy. So the take-home message here is that if we fail to plan, we are planning to fail. Anatomic reduction and stable fixation is the aim for us. Understanding of anatomy and morphology of the fracture by spending time with the imaging is very important. Planning and execution of appropriate exposure. Stepwise sequences should be followed from preparation of fracture bed to temporary and definitive fixation. Thank you for your attention.
Thank you, Dr. Vijayanand. I would like to ask you one question.
Yes,
the
sir.
spring plates which are available, they are from the Synthesis, which are very expensive.
Yes,
Can you tell how we can prepare the spring plates from our reconstruction plate?
So usually if you do not have the anatomic spring plates, we can very well prepare it with 1/3 tubular plates.
Yeah.
We get the plate at the hole and the two points of the plate can be bent as a hook and then the original plate is over contoured and in that way it acts as a spring plate.
Yeah. So
And also use small reconstruction plates which were available on table. We can still create a spring plate even with a reconstruction plate, but the tiles they do not get that sharp. So ideally is a 1/3 tubular plate if you want to modify it.
okay. What is your opinion regarding sometimes you see the acetabulum large pieces are also avulsed. So what do you do in those cases if they're avulsed?
Usually I keep anchors ready.
Yeah.
Whenever we cannot fix it with some screws, we can adapt it with anchors.
Okay. So thank you, Dr. Vijayanand. Now we have come to a thing that we had done a temporary fixation, and now we are going to go for a definitive fixation. So I request Dr. Manoj Purvalkar to just tell us templating, countering with the plates, and how we are going to put the plate and the direction of the screws. And that is on the bone model, so it becomes very easy for us to understand.
Yeah. So yeah, again, good evening to all of you again. And first of all, thanks MOA President Dr. Gadegone sir, Dr. Kothadiya sir, Dr. Kimmatkar for giving me this opportunity. So the topic which has been given to me is about the templating and contouring of plates with fixation and direction of screw placements on the bone model. So what I try to get out the 10 points by which you can have an ideal plate and the screw trajectory or directions correctly if you want to fix these complex posterior wall fractures. The first is like these acetabular fractures are very complex. So you need to understand them, very essential to have a pre-operative templating in your mind before you start your surgery. You need to know the exact point, starting from point of your screw, where you want to get the optimal screw anchorage into your bone. And even a slight difference if you make in your screw direction, it will dramatically change the substance of screw penetration directly. So why it is important? It is very essential to have a maximum length for the screw, because these are not bicortical kind of bone. These are the cancellous kind of bone. So yeah, so as to prevent the screw loosening and fixation failures, which are very common, you need to get the maximum length of the screw, avoiding the articular surfaces. The second point in the posterior wall, as you can see here, that the direction of screws in the posterior wall are not perpendicular. They are tangential to this posterior cortex of this posterior wall of acetabulum. You can put those tangentially or could have some small angle to this surface. You need to see this orange line. If you could see, this touches the articular surface of the posterior wall. So no screw should go beyond this line. All these red lines which are shown over here are dangerous. Try to be your all screws in this green zone. Another important point which has not been focused till now is that it is not in the plate. These the optimal and the final construct for posterior wall fractures is ideally initially the fragment specific fixation, either with this lag screw or the spring plate, as well as then later on stabilizing it with a posterior wall plate. So both these combinations are very important to get the final fixation. So as far as the lag screw fixation is considered, you need to identify and locate these individual fragments. You can put 3.5 screws very easily if these are quite big enough. Sometimes these fractures are, the fragments are too small or too peripheral, or even now some labral cartilage avulsions are there, where you can go for mini fragmentary 1.5 or 2 mm screw fixation, spring plates or anchors, but never 4.5 mm screw, which is needed in this lag screw. Another important is to have these zones very clear, that the 10 millimeter of acetabular rim is considered as the red zone. You should not try to put screw in this region as far as possible, because the trajectory will itself make it more dangerous due to the concavity of acetabulum, and the chances of joint penetrations are very high. So you need to go for this green zone, which is just medial to this danger zone, and here you can angle them posteriorly and still avoiding any intra-articular penetrations. So again, this is a very important CM image when everybody should have once you placed a single or other screws or even the plate. This image with an excessive obturator oblique view or a direct lateral to the acetabulum, you can certainly be sure that all of your screws, they are all extra-articular. So further moving ahead, after the lag screw, very important to put plate. How does this plate helps? It stabilizes the posterior wall fragments directly with their points. And additionally, the surface area of this plate would additionally act as a buttress. And as already pointed out, these plates, the reconstruction plates, they should be under controlled. They should be slightly less curved, so that the underlying bone, after tightening the screws, the fracture will compress and stabilize the reduction. Usually the flexible aluminum templates are used. Another sixth point is the where would you put this plate? What is the optimal plate positioning? One must understand it is on the peripheral or the lateral aspect along the acetabular rim. So what common mistake we usually make is to put this plate slightly medially, parallel to the sciatic notch. Again, this will cause a lot of trouble. You should not try to violate the gluteus medius cranially. This further exposure is limited by the superior gluteal pedicle, and you cannot extend cranially beyond the apex of the sciatic notch. So try to avoid putting the plate medially. So this is the ideal X-ray which one should look after once you have put the plate. So here you can certainly see that the plate is far lateral along the acetabular rim. So this is the ideal position for your plate. So this is a video where you can see the plate application and contouring which has been talked about. Here the 3.5 mm reconstruction A12 plate is used. It should span the whole fracture, either two screws proximally and distally. This is a straight plate which is usually sometimes recommended because it is more flexible and malleable and you can bend them properly. It starts from the distal ilium to this ischial tuberosity. So before putting this plate, one must do a templating. So this is with this aluminum kind of plate which is available. The first you need to locate the position where you wanted to place your plate. It should be more towards the lateral aspect near the edge of the acetabulum, and either one or two screws proximally and distally should be planned. The length will depend on that. And then most important, this is the crucial, like the acute bend he will have at this ischial tuberosity distal region, where you can see that to mold the plate here, you will have at least more than around 90 degree of bend for that screw. So this is very crucial. So once you take out this template along with this proximally along the ilium, so this is how this plate bending should be done. The ideally, again, they are recommending the straight plate, but sometimes you can use the curved plates as well. The ease of that, this is our more malleable. First step is always to go the curve along the edges. You need to bend along the edges, and you again try to align along the acetabular edge. And then you can go further molding of this plate, contouring in the convex or concavity as per whatever template which you have chosen. Like here, this is the acute bend which is needed near the ischial tuberosity. This is the proximal. You need to have multiple bends to get the concavity at that site properly. And this is how this plate will anatomically fix over that posterior wall region, so that you can get a good one or two screws proximally and distally. Then the sequence of screw fixation, as already told, these are the under reduced or under contoured plates. The first screw is always to the ischium. The last but one screw where that bend is there. Then you need to attach this plate proximally to the ilium, and then you can tighten that screw so as to complete that plate contouring and could compress that fracture fragment. So this is this further video where it can demonstrate clearly. This is the last but one screw near that bend. This is always the first screw near the ischium tuberosity. You can see the direction. You will not be able to see the joint most of the times, but here if it is directed posteriorly, you can measure the length for this screw. Try to get the maximum coverage, maximum length of this screw as possible, because these screws will firmly, you can see this direction again here, that it is quite very well placed posteriorly. Again, you can make that first screw loose, so you can then again see how you are trying to plan that superiorly. It should not be again too medial, it should be more towards the lateral, towards the ridge. And then this second eccentric screw is planned, so that this eccentric screw at the most proximal end will try to give the compression. You can alternatively compress each of these screw, tighten this screw so as to get a good compression at this fracture site, so as to completely buttress this fracture fragment along with the points of the plate, or along with the surface area. These interfragmentary screws are ideally recommended, but again, they are sometimes more superficial. You need to see the direction of these screws so as to they don't penetrate. Put 2 screws at least proximally beyond the fracture line. And this is the most important screw, which I think every acetabular surgeon would like to have into the acetabular, the ischial tuberosity. Again, a very long screw is usually done. And this final screw will complete your plate fixation. It is recommended that once you have put up this plate, then you can go for more further interfragmentary compressions if you have placed your lag screws. Another, again, this excessive obturator view, which was shown to so as to see that there are no screws which are penetrating the joint surfaces. So coming back to the interfragmentary screws, again, they are desirable, but they are not always possible. Again, as I told them, these are the having superficial trajectory, but if possible, they should be done and should be checked for any intra-articular penetration. I think Vijay has already told about these spring hook plates which resist the shear forces which are created by the compression, and you must try to neutralize these forces with such kind of these hook plates. Again, these hook plates, one or two important points that they should be applied with points of individual fixation which are far medial to this acetabular surface. So this posterior, you need to add additionally this posterior buttress plate which overlies this spring plate so as to secure them peripherally. The final point is like we need to have a good final radiographs so as to assess the evaluation whether you have done a perfect job or not. So you try to see the reduction quality, concentric reduction of your residual subluxation, articular congruence. You need to see whether there are any intra-articular penetration, screw lengths. Very difficult sometimes to assess these posterior wall fractures because it is obviously a femoral head which is overlapping to this. So sometimes you can see some gaps or shadows on this posterior rim, particularly at the caudal end, and these are the indicators where you are seeing that these are the imperfect reductions which could have been there. Finally, there are few new implant designs which are coming up so as to tackle the problem of spring plate with the reconstruction plate, but I don't know whether how much biomechanically they are better. And these are certainly available like hooks which we sometimes put in the volar plate of the radius so as to grab that volar fragment. Like here the acetabulum labrum is there, so they are tried to additionally fix those, try to compress those or buttress those fragment with this kind of plate. Again, it is experimental, but certainly these newer kind of plates sometimes would be needed for these few of the indicated posterior wall fractures ahead. So I thank you very much again for your kind the patient listening, and thank you again.
Thank you, Manoj, for an elaborate and excellent talk how to counter the plates, how to put the screws. Now, is there any test to know whether the screws are intra-articular or not? How you after passing the screws, is there anything you do it to know whether the hardware is intra-articular?
Yeah, the foremost is the direction and the initial starting point of the screw. So if there are initially I try to see the acetabular rim properly, and I could get the concavity with eyes particularly, and then it is usually the hip movement sometimes you can check, and I think the Siam images only will be the best indicator to determine whether these screws are intra-articular or not.
Yeah. There is the things which I usually do. I just drill the hole in the direction towards the retrosadic nerves, because there you get a very good bone quality to hold on the screws. After drilling drill bit, I take out the drill bit and put a wire into that hole and then move it. If the screw is intra-articular, the wire will move. If it is not intra-articular, the wire will not move. That's the way I usually confirm whether the screw is intra-articular or not. That is one way to do it.
Okay.
And second thing about the spring plates, the spring plate has to be very well seated. It should be hooked to the fragments and it should not overhang onto the acetabular margin. Otherwise, it starts eroding the head of the femur. That is to be taken consideration. For putting up the screws plates, I think there are 3 zones they are described in the posterior wall. Usually, a middle zone or a little bit towards the rim, we usually put the plates rather than going too medially, as you said rightly.
Yeah.
Okay. So very sincere thanks for your elaborate and very excellent lecture. So, dear friends, we have seen almost all the types of fixation, right from the posterior wall, we have seen everything, covering everything, except if you get fractures which is higher up, which is the dome, near the dome, and you are not able to visualize that fracture. So how to proceed with this type of fixation? You need something to do for fixation of this fracture. So here I request Dr. Milind Joshi just to come and highlight how we are going to fix the fractures which are higher up by the trochanteric osteotomy.
Good evening, all. And at the outset, I thank Dr. Kothadiya sir, Dr. Gadegone, and MOA team to give me an opportunity. Now, let us see when do we do the trochanteric digastric flip osteotomy. So, this particular osteotomy is used whenever you want to increase your exposure. And it is called as digastric osteotomy because attached to it. And from above, there is a gluteus medius, and from below, the vastus lateralis is attached to the trochanteric fragment. So, what are the indications where you would be needing to do the trochanteric flip osteotomy? The indications would be when the fracture geometry is such that the fracture is situated in the antero-superior acetabular area. So there, with KL approach, it's not very easy to apply a plate over there. You will have to struggle. A more important indication is in certain transverse or T-shaped fractures. It's not today's topic, but then I have to cover it to assess the accuracy of reduction by visual and digital intra-articular palpation, where you would be combining the flip osteotomy with surgical hip dislocation, and there you can pass actually the anterior column screw from the posterior side into the anterior column. Now, sometimes the acetabular fracture is associated with fracture of femoral head, and when you want to tackle that, then that flip osteotomy and surgical hip dislocation would definitely be helpful to you. So for place this, I have already talked to you that whenever you want to place an anterior column screw, and then rarely, if by giving traction, you are not able to remove that particular bony fragment, especially when it has gone anterior to the femoral head and it's a sizable fragment, then you may have to resort to a surgical dislocation and trochanteric flip osteotomy. And more important indication is when the patient is presented late, has presented to you late, and it's practically a maluniting or malunited situation where the ease of exposure, for ease of exposure, you would need this particular osteotomy. So with a routine Cocker-Langenbank approach, this is the area of access. So if you add a trochanteric flip, so that obstacle has gone, and then this much area right up to anterior inferior iliac spine is in front of you, and you can place or you do your work over here. And when you combine it with a surgical hip dislocation, that is the Gans dislocation, this entire area would be in front of you. Now, the practical importance of doing this particular osteotomy, Dr. Nitin sir has already told us that it's the medial circumflex femoral artery. Its branch is having a communication with the trochanteric anastomosis, and it runs in very close proximity to the obturator's external tendon, and therefore if we preserve, when we do the osteotomy, if we will see that in a while that we must try to do every attempt to preserve the blood supply. So if we try to save this medial circumflex femoral artery while doing the osteotomy, that the avascular necrosis will not occur. So this is just to show the blood supply, the medial circumflex, and there is a subsynovial the vessels which will be going to supply the femoral head, every attempt has to be done. Therefore, the external rotators need to be cut at least 1.5 centimeters away from their insertion site. Now, for giving you the orientation, this is the cranial end of the patient. This is the foot end. This is the trochanter. This is vastus lateralis. This is anterior side, and this is gluteus medius. So, whenever we do that osteotomy, it is near the posterior border of the gluteus medius, and if we try to retain 20% fibers of the gluteus medius, the chances that we will not damage the the blood supply of the femoral head are significantly higher, and we need to expose around 6 to 7 centimeters of the vastus lateralis from its posterior aspect, so that when you take this fragment anteriorly, the tension on the vessels, the superior gluteal vessels, also is less. So now we will just see a video of this particular how it is done.
It starts superiorly at the tip of the greater trochanter, in line with the insertion of the gluteus medius, and runs inferiorly to the posterior edge of the origin of the vastus lateralis as it attaches to the vastus ridge.
And here we are releasing the vastus lateralis.
The posterior aspect of the vastus lateralis is elevated over a distance of at least 6 centimeters. The more released, the less tension there is on the muscle.
And now we will be,
the release continues anteriorly so that a Hohmann retractor can be placed over the anterior aspect of the femur.
We will be putting the Hohmanns anteriorly, taking the vastus lateralis anteriorly now.
The bone on the posterior aspect of the greater trochanter is exposed to allow for the osteotomy cut. This may be a simple transverse cut or a step cut. Here, a step cut is used. This is the surgeon's preference. The osteotomy is made along the line from the posterior border of the gluteus medius to just below the vastus ridge. The saw blade is oriented upward to.
Here it is the assistant. We have to give attention to how the assistant is holding the foot. If he is rotating it internally and you are directing your saw blade anteriorly, you can cut the femoral neck also. So that has to be kept in mind.
Cutting into the neck, but still assuring that an ample amount of bone is taken to avoid fracturing the fragment. The trochanter may be pre-drilled for later screw fixation of the fragment. A saw blade is placed in the proximal cut to help guide the orientation of the saw blade for the second cut.
The distal cut is little more posterior, near the vastus lateralis part, and sometimes it's a good idea to pre-drill it before sawing, pre-drill with small K wires. And now we will complete that particular step cut. The advantage of this particular step cut is that it is inherently more stable, and if it is in a step cut fashion, then the chances of migration of the trochanter would be definitely very less. So now you can see that there are two different
Two blades are placed in the osteotomy to illustrate the different levels. A small osteotome is used to cut the step. The osteotomy is now complete. This allows for a partial osteotomy and a fracture to occur, which enhances the fixation. As the osteotomy is raised, fibers from the gluteus medius will need to be resected, as well as some of the gluteus minimus.
So that step cut makes it more inherently stable, but then it's not all that easy to perform that particular step cut. Roughly 1.5 centimeters is the size of the trochanteric fragment in the superior part, and in the inferior part it is slightly less. So we are taking it anteriorly, and once it is taken anteriorly, the dome and the superior lateral surface of the ilium near the dome is completely visible, and the further part of capsulotomy and surgical dislocation we are not supposed to deal it with in this particular top. Now, whenever you want to fix
The
it,
osteotomy is now reduced
so
and
you will reduce
stabilized with
it,
2 or 3 screws.
and you can fix it with either tension band wire or 3.5 mm cortical screws or 4 mm CC screws, and the fixation is, that much fixation is definitely enough.
Depending on its size.
So one screw is for fixation of this part, and the another one is fixation for the lower part. You can see that. Now, honestly, these cases have been done with my teacher, Dr. Pradeep Kothadiya sir, and this was a delayed presentation where patient could be taken only after already 3 weeks had passed. Therefore, we had to do a osteotomy. In fresh cases, by merely abducting the limb, we can take off the pressure on the superior gluteal vessels as well, superior gluteal neurovascular bundle, and so this is rarely needed in proper posterior wall fractures. So this is one example, and this is where this was fixed with tension band wire. The complications of this particular osteotomy is whenever you especially play with or release with the gluteus minimus, they have found the chances of heterotopic ossification bit higher, but that really doesn't matter as far as the functional outcome is concerned. And so if you are not, the surgical technique is not good, then the chances of delayed union and of the osteotomy are definitely there. And obviously, if your technique is improper, then you can still get out the AVN. So, thank you.
Thank you, Dr. Milind, for an excellent talk on the digastric osteotomy. So the chances of, you said the chances of non-union or malunion, non-union is a little bit more in trochanteric osteotomy, but it is more, whether it is more in digastric type of trochanteric osteotomy or it is more in the step cut type of osteotomy?
Sir, in digastric or can be either a step cut or a simple. If the fixation is improper, then the chances of malunion, non-union or delayed union would be more. In a step cut, it's more stable inherently than a simple sliding type of osteotomy.
So according to the step cut, osteotomy is a better, which is more stable and it chances of union very high.
Because of that step, that trochanter cannot ride higher up.
Okay. So, dear friends, I think almost we have covered every part of our talk on posterior wall fractures. Anybody has got any questions on the posterior wall fractures? To complete this, this is a patient. This is a patient which has got a fracture dislocation. Is the iliopectineal line, ilioischial line intact. The anterior wall line is intact. Ideally, the posterior line should all be like this. This is the posterior line. So this is a defect. Where is this defect? This is a fragment which is there on the top of it. The two views definitely gives us a better view about the joint as well as In the obturator oblique, you can see definitely a very good subluxation or dislocation of the femoral head. In iliac oblique also, in such patients, we don't see much things. Only if it is an articular incongruence, you will be able to see in these views, nothing else. These are different lines again drawn just to show, complete the list. Here you can see a very good articular impaction. You can preoperatively diagnose articular impaction in the axial view. Here you see the dislocated femoral head. The femoral head is not in the socket, and definitely you can see here articular impaction also in the coronal planes. So this is a subtraction, femoral head subtraction, 3D CT scan, which shows again articular incongruity or impacted fragment. So the case which has been shown to you shows us there is a dislocation, there is articular impaction, there is a wall fragment which is there, and the fracture is unstable. So this is the way the articular impaction looks like. This is the way you reduce it and fix it with use a bone graft to fill that gap, and you can use either a direct screw or you can use a screw through the plate as a raft screw. This is a screw which is the raft screw. So this is iliac oblique view and obturator oblique view. This is a complete. We have tried to cover almost everything about the posterior fracture dislocation of the hip. So anybody has got any questions on that now? Are there any questions in the chat box? Manoj or Nitin?
Yeah, I think Dr. Nirbhay Karandikar sir has joined.
Yeah.
Yeah. Nirbhay, any queries or questions you have? Okay, I think we'll go ahead with the second case, I suppose.
Yeah. So Dr. Nitin Kimmatkar is going to be a moderator for the next case.
Good evening. Is my presentation seen on the screen?
Only your,
only your screen, not the presentation.
Not your presentation.
Okay. Now?
Yes, now we can see it.
So this is a 28-year-old male, came with an history of vehicular accident. This is an isolated injury, and he is an hemodynamically stable. And this is an X-ray in the casualty. So further, as we have discussed about this line, iliopectineal line is disrupted, ilioischial line is disrupted, roof as a part of roof is disrupted, this disruption of teardrop, anterior rim is broken, posterior rim is broken, and there's some invisible part of some inferior pubic ramus is also broken. These are Jude views, and this is a CT scan. Let us see. These are 2D images. So we have a posterior column fracture in our question. I think we should stop here. Let us make the memory of this case as we progress around our further lectures. I will ask Dr. Vijayanand Lokhande to illustrate something about morphology of these fractures. I will stop share.
You stop the sharing the screen.
Yeah.
I do have one question over here.
Yeah.
Yeah, what is the utility of this inlet outlet Judet views? You see this X-ray in the casualty, obviously an acetabullar fracture, and you go for CT scan.
Yeah.
So are they still recommended any additional thing which you could get out with this inlet views?
I think what is the traditional learning is there. Whenever you are going for an this robotic fixation of these pelvic fractures, you should know what structure you are going to see in each of these views. Where is your ASIS is located? Where is your anterior spine is located? Where is your PSIS is located? So unless you look on those specific X-ray and you are judging all those points in your back of your mind, you are not going to get a 3D visualization as well as percutaneous screw placements of your point of fixation of that screws in your mind. So it is better that we should learn on the traditional aspect and build on our knowledge on the 3D CT scans, 2D CT scans, and then progress towards the fixation. I think the post-operative CT scan is also a great learning tool. You should, whenever you fix your fracture, you should always get your post-operative CT scans also. That is, whatever mistakes we do in surgical tactics, we get to rectify as and when we get mature in your surgical fixation. It is this pelvic fracture has a great learning curve. Everybody should be very humble, and we should not be very that we're so much confident about the things that every fracture is a different fracture, and every fracture will teach you something new thing in your teaching and learning curve.
Okay. Manoj, I think your question was, in the days of these days of CT scan, whether you need to take a Judet views or not. Am I right?
Yeah.
You wanted to know that. Yes, I do agree. When you are doing a CT scan, there is no need to take these spatial views because they will be also covered up in your CT scan. Okay. But these other views are required in post-operative follow-up. You are not able to do CT scan every time. So you can definitely take other views for the follow-up X-rays.
Yeah, that is true. Post-operative, they are very essential.
Yeah, so that's the way you when we were doing our acetabullar fractures, that those days there was no CT scan, so we have to believe more on these views. So this is like a protocol having these 3 views for every acetabular fracture. But everybody should know these views so that they can take in the post-operative period and they can understand what are the things you are going to see in these views.
Okay. I would like to add some points in that why do we need to do that Judet views here?
Yeah.
So I think that it also depends upon the quality of CT you have. In many areas, the CT scan, even if it is a 3D scan, many of the fracture lines are missed on 3D CT. And whenever we plan for fracture fixation, we get quite good views, means access by assessing all 3 parameters. The 2D CT, just the 2D CT becomes too complex to understand the anatomy. So the combination of Judet views plus the 2D CT plus the 3D CT gives you exactly knowledge about the morphology of the fracture. So it is not just that CT gives everything. So that's my take. So I would discuss something about the morphology of posterior column as well as the posterior column with wall fracture. So we need to understand that fractures of the posterior column, it encompasses the elementary type because it has a single fracture line. Therefore, we call it as elementary. In that case, the anterior column and the ilium remains intact. The femoral head displaces with the posterior column fracture. This is a very important point. We usually do not give that much of importance to this, but it is an important point, I think. So usually they form just about 3 to 4% of acetabular fracture, the isolated posterior columns or the posterior column with wall. But we have to know the morphology or understand this fracture very importantly because it is usually it is always a part of associated root column fracture. and it is always then associated with a T-type or a APST, associated anterior column with posterior hemitransverse. So the posterior column, I think, understanding should not be just limited to the posterior acetabular fractures. It is a part of many other fractures. So posterior column as such becomes, it just does not compass only 3 to 4% of acetabular injuries. So this occurs because of a posteriorly directed force, and it depends upon the degree of flexion and extension of the hip, as well as adduction and abduction, that where the fracture occurs. But it is usually posteriorly directed force. If we come to morphology of the fracture, the common type of posterior column fracture, it starts at the sciatic notch, then it descends obliquely down the acetabular surface. It crosses the condylite fossa in the most posterior region. This is again an important point. I will come up to it again. And then it finally disrupts the ischial ramus. Therefore, we call it as a column fracture because it is whole of the column is disrupted from the rest of the pelvis or the acetabulum. When we see it from the inner surface of the pelvis, the fracture line usually descends obliquely along the quadrilateral plate and extending in the inferior ramus. So these are too much repetitions, but they are very important to important for all these acetabular lectures. So if you come to radiological coordinates of this AP view, here we can see that the iliopectineal line is intact, the roof is intact, the anterior border of the acetabulum is maintained, the teardrop is mostly intact. Mostly, it is not that always the teardrop will be intact in posterior column fractures. I'll come to that. There we can see a large posterior column fragment there. And when we see the femoral hair goes along with the posterior column, here the capsule of the posterior hip joint, it remains intact. Therefore, it takes the head along with it. It is a bit different from posterior column with posterior wall fracture. When we see the obturator oblique view, we can see here that the anterior column is intact, but the intactness of the iliopectineal line, the roof is intact, and there is breach in the obturator foramen. Coming to the iliac oblique views, we can see a very large displaced posterior column fragment here. We can also see the cranial extent of the fragment, and the roof is intact here. As well as there is intactness of the anterior wall or column. When we come to 2D CT, we see that there is separation of the posterior column from the intact innominate bone. The posterior column itself rotates internally as well as displaces posteriorly. It goes inside the true pelvis. Therefore, it takes the femoral hair along with it. And if we see the 2D CT cuts, the femoral hair is aligned with the articular surface of the displaced posterior column fragment in this view. There is another variant which we call it as an extended posterior column fracture. Here, what is the difference? Here we can see that there is some disruption of the iliopectineal line here. Also, there is a displacement of the teardrop medially as well as a large posterior column fracture here. As in my first slide, I have said that the typical fracture descends down the posterior part of the condylite fossa. But when the same fracture extends more anteriorly, because teardrop, actually the radiological teardrop is located more of anteriorly in the acetabulum. Therefore, when the oblique line descends more anteriorly, it takes the teardrop along with it, and here we can see the displacement of teardrop also, as well as some breach in the iliopectineal line here. We show the intactness here of the iliopectineal line, and we can see a large posterior column fragment here. So if we see the 2D cuts of this extended posterior column fracture here, we can see that the fracture line, oblique fracture line, is extending too much anteriorly. It is not the usual location. Usual location of posterior column fracture lies posteriorly here. So the blue arrow indicates the intactness of the anterior part, and the yellow arrow shows the very anterior extent of the oblique fracture line. Therefore, we call it as, therefore the teardrop is shifted medially. So we call it as extended posterior wall. The diagrammatic representation can be done like this. Here we can see the iliopectineal line remains intact, but some part of it comes with that wall. So we see a minimal disruption there, but not actual disruption. This is the actual extended posterior column fracture. So let's see from Dr. Pradeep Emade. We can see a large fragment extending too much anteriorly along the brim at the quadrilateral surface. This is an extended posterior column. There are also other subgroups here. I don't think we need to go too much in detail. Coming to posterior column with posterior wall. This is again a rare injury, but again this can occur with both. It can be a combination of both column fracture as well as the transverse with posterior wall or T-type fracture. We can get this combination. Anterior copper and ilium remain intact. The important point here to be noted is that here the posterior column is usually incomplete or minimally displaced. In isolated posterior column, the posterior column goes along with the femoral head, or the femoral head goes along with it. But here, the posterior column remains minimally displaced and the wall is displaced majorly. So this is again an EP X-ray. Here we can see that the iliopectineal line is intact, the ilioischial is broken. The teardrop is intact. We can see a large posterior column fragment here. Also, you can see a triangular piece of posterior wall and the anterior rim is intact here. The posterior rim is disrupted, indicating the posterior wall fragment. The same iliac and obturator oblique views showing the posterior wall fragment here and the rest of the parameters. So when we combine these two fractures, the posterior column on one side and the posterior column with posterior wall on another side, we see that in posterior column, the column is widely displaced, and in posterior column with one, the column is less displaced and the wall is not displaced. The femoral head is congruent with the posterior column. Here, the posterior femoral head is congruent with the posterior wall. It does not go along with the column because the wall has the capsule along with it. The posterior column goes away from the capsule, therefore it does not take the femoral head along with it. Posterior column, the head displaces centrally. In the column with wall, the head displaces posteriorly. This is an example. Here we can see a large posterior wall fragment here, but the posterior column is minimally displaced, or just a break in this line here. This is a typical case. And in this 2D CT cuts, we can see a posterior extent of this posterior column. So this is a typical posterior column here, the posterior extent as well as the posterior wall here. It was managed in a routine way. In this case, we need to fix the posterior column as well as the posterior wall with buttress plating. It was done with 2 plates like this. So the take-home message here is that all these injuries occur due to posteriorly directed forces. The spectrum can vary from isolated injuries to badly comminuted column as well as wall, along with proximal femoral injuries. We can have varying degrees of impaction and comminution in these cases. So understanding pathoanatomy is crucial to formulate the appropriate treatment plan. Thank you for your attention. Thank you.
Thank you, Vijayanand, for an excellent lecture elaboration on the morphology of fracture. It's very good. You explained it very nicely.
Thank you.
Now, after this morphology, after the diagnosis of this fracture, now we need this fracture. So there is many difficulties in reducing this fracture and there are some strategies to fix how to fix this fracture. So now I call upon Dr. Venugopal Sambharam just to highlight us on the methods of reduction and fixation.
Yeah, I will be dealing with, am I audible?
Yes.
Yes.
I'll be dealing with methods, reduction techniques, and fixation strategies. We will see some of the instruments and implants which help us to get the fracture reduced and how they are used in each case. The instruments used are shunt spin with chuck, ball spike pusher. It can be single or pointed, or it can be spike disc pusher. It can be straight or curved. A pointed reduction clamp, also called as a Weber's clamp, a Farabaug's clamp, a Jungbuth's clamp, small offset clamps, plate as a reduction tool and a spring plates, K-wire as a toothpick, and bone hook. So we'll see each of these separately. Now traction, as we have seen, Vijayanand had told that in the posterior column fracture, the head displaces medially and posteriorly and internally rotated. So traction is useful for achieving reduction, distraction of the joint, and to see for any loose bodies. And this can be achieved by a lateral traction or a longitudinal traction, which can be applied manually or along with the femoral distractor. This is a lateral traction. Classically, what we see, a pin is placed, shunt pin is placed in the femoral head and neck, and the posterior column, as it is displaced medially, we can pull it out helps in the reduction of achieving the posterior column. And this is the traction, longitudinal traction with the use of femoral distractor, where a pin is placed in the supraacetabular area, which is the strong bone, and another is placed in the upper third of shaft of femur. This avoids pulling by a person intraoperatively, as the person can get exhausted, but it limits the mobility of hip. Shunt spin with chuck in the ischial tuberosity. How it helps? It is typically applied through the muscular insertions overlying the tuberosity. The muscles need not be elevated from the bone. It is used as a handle or joysticks to manipulate the fragments. A 5 mm shunt spin is used. It is inserted in the ischium so that we can rotate the ischium externally, because the posterior column after fracture usually rotates internally and can be moved in all directions so as to get the reduction. This is how shunt spin is placed in the ischial tuberosity, and it can be rotated in all directions. This is just a video demonstrating. Now this is the fracture surface of the proximal fragment, what we see, and this is the distal fragment. We have placed a shunt spin in the ischial tuberosity, and now we are manipulating with the help of shunt spin, joysticking, to get the reduction. Once we get the reduction, then we can drill 2 small holes on the proximal distal fragment, and with the help of Weber's clamp, we can get the fracture reduced and well compressed. And now we can check the reduction by putting a finger on the quadrilateral plate and the anterior surface, and once it is well reduced, we can fix it to the K-wire and keep it held until we put the definitive fixation. So this is how a shunt spin can be used for reduction purpose. Second is the ball spike pusher. This is how a ball spike pusher is seen. It can be used with the disc pusher. Now the importance is, if you use this in an osteoporotic bone, it can pierce and go inside. Thus, this disc pusher dissipates the single point force, and this can be used in osteoporotic bone. This is how it is used in a posterior column fracture. First, you have to drill a hole. Then, with the help of ball spike pusher, now you can push this fragment superiorly. This is how in a wall fragment the ball spike pusher helps. We can have the pointed reduction clamp or Weber's clamp. This is how it is used. We have to drill hole on either fragment, and then we have to place the tongs on this. With the help of the shunt spin in the ischial tuberosity, we can compress the fracture. This can also be used by placing one tong internally and other tongue outside, but you have to be careful because you will be having some superior gluteal vessels around this. You should not injure that. This is called as a Farabaug's clamp. This clamp has jaws shaped to fit around the screw heads. This is how the inset or the zoom picture looks like, wherein a screw head fits at this level, and we have to use 2 screws in either fragments to achieve the reduction. This is how 2 screws are used, placed initially, and then a clamp is used to compress the fracture. This is how it looks, so that you can compress the fracture and get an accurate reduction. This is Jungbu's clamp, used along with 2 cortical screws in either fragments. Here, if you see, it is having holes to hold the screws. This is one screw, another screw, and the specialty of this clamp is it can be used as a distractor or a compressor device. This is how it is used. You have to place 2 screws on either fragment. Then, if you use inside, it can act as a distractor. If this comes outside, you can use it as a compressor device. This is how a fracture can be compressed and well reduced along with the shunt spin in the ischial tuberosity. The use of the screw-dependent clamp, that is Jungbu's clamp and Farabaug's clamp, causes some difficulty in fixation of the plate and screw. Definitive fixation of plate comes in the way. You have to adjust that and go ahead. Or another is a small offset clamp. Here, one tongue is, again you have to drill small holes here in the proximal fragment, in the distal segment, small holes, and you can compress. Or alternatively, it can be used inside, one tongue placed inside and other outside, you can compress that. Use of a plate to use as a reduction tool. If there are 2 fragments in this way, a plate can be placed. In one fragment, a screw can be placed. Later on, you can pass another screw, and as you go on tightening, this fragment gets compressed off. Here is one example where the posterior column is gone inside. So when you place a plate and as you go on tightening, the fragment, distal fragment will get pulled and will get well reduced. The use of spring plates has been well illustrated. I will not go in detail. We are knowing all the details. And after we put a spring plate, then you can, on the top of that, you can add a wall plate also. K-wire can be used as a toothpick. Sometimes wall or column fragments may be so small that you cannot hold with any devices, then the K-wire becomes very handy. This is how a small fragment, a K-wire is used, and you can manipulate, and then you can pass ahead the K-wire and temporarily fix and go ahead with the definitive fixation. Bone hook can also be used as a reduction device, but it can be used, but with caution. The tip must be blunt so as not to injure the neurovascular structures around it. This is how a bone spike is used. You can lift up the distal fragment which has gone medially. Now, what are the fixation strategies? Always get the reduction of the posterior column first, as all measures discussed earlier, and then start the fixation. If there is a sharp spike of the posterior column, then one can excise it to prevent the injury to the superior gluteal artery. Fixation should be always column first and then the wall. Visualization of the fracture along the cortical retroacetabular surface and palpation of the fracture along the quadrilateral surface together will indicate the quality of the obtained reduction. That is, quadrilateral surface should have no palpable gap or step off. This is how a finger is put inside. We have seen, everybody has illustrated and elaborated very nicely. Then later on, once we get the reduction with either of the method described earlier, then we can temporarily fix with a K-wire. It can be fixed with the interfragmentary screw, or sometimes 2.7 small mini plate can be temporarily used on the other side. Then we can place a plate here. We should use a recon plate 5-hole with 2 screws in the proximal and 2 screws in the distal segment. Over contouring of the plate is done so that there is no opening anterior. This is especially for the posterior column. In the wall, there is under contouring, but in the column, there is over contouring so as to prevent the opening anteriorly. Plate positioning will be limited cranially by the superior gluteal nerve and vascular pedicle. This is how ideally a posterior column is fixed, 2 screws proximally, 2 screws distally. Then proceed for the fixation of the wall fragments. Once this is over, then we use a template for well buttressing effect of the wall fragment. This is how a template should be pushed from distal to the proximal end. Aluminum template, as Manoj sir has shown. Then with the plate bender, as he has very well demonstrated in the video, we give the shape of the plate and then we buttress that wall fragment. This is how it's done. And screws should be always directed away from the joint. This is very important. It should not come inside. Use of an interfragmentary screw for the wall fragments. Always reduce the wall fragments and then compress with the use of ballpoint spike, pointed reduction clamp, etc. And then pass the IF screws. After passing K-wire for interfragmentary screw path, always check with the thin wire so that the screw is not intra-articular. As Pradeep sir had told, this we call it as a dancing K-wire technique. We have learned from sir only. We put a small K-wire. Suppose if you have drilled with 2.5 mm path, we take 1 mm K-wire, we put in that, and we ask the assistant to rotate and move the head. And if the K-wire is not moving, then it is not intra-articular. Then we proceed with the wall plate. Plate for the wall fragment should be at least 8 to 10 mm medial to the margin of acetabulum. Otherwise, it can cause erosion of the femoral head. IF screws with plate. Here, 2 IF screws are seen for the wall, and then over that, this is the wall plate. Spring plate, we have seen very well. Everybody has illustrated. Occasionally, posterior column screw can be used. The starting point is at the ischial tuberosity, and the finger in the greater sciatic notch is used as a guide for the wire. This is also called as a butt screw. This is how it looks. We can pass a IF screw, and then over the top, we can put a wall plate. Intraoblique C-arm fluoroscopy is very important. This is to confirm the fracture reduction quality and the congruence of the femoral head. Here are the few cases. This was a posterior column with wall fracture. This is the CT. And this was how it was fixed. And we have used interfragmentary screw and a wall plate and a column plate. This was another case, dislocation of femoral head with posterior column wall fracture. This is how we have fixed column plate and a wall plate. This is third case, posterior wall fracture, a big fragment here. You can note that interfragmentary screws have been used, and over the top of that, wall plate has been used. Thank you.
Thank you, Venugopalan.
Yes,
you
sir.
have illustrated every reduction techniques whatever is being described. I ask now Dr. Nirbhay Karandikar to speak on tricks to avoid complication for posterior fixation and recent advances on HO, heterotopic ossification. Welcome, Nirbhay. You are muted.
Am I clear now? Is it better?
Yeah.
Okay. Thanks for everyone for hanging on to this last bit of the whole thing. And my talk for today will be on tricks to avoid some complications. And there is nothing that screws up your result as a complication in the post-operative period. And so we'll try and talk to you about that. Just one second. Yeah. So I'd like to thank Dr. Kimmatkar, Dr. Pradeep Kothadiya for thinking of me for this little talk, and of course MOA. And I think it's a fantastic thing to have a young surgeons forum. I've been seeing the rise of the career graph of Dr. Lokhande with immense pride, as Dr. Gadegone and Dr. Lokhande have been really immensely important when it comes to the young surgeons forum. My learning objectives for today are, of course, to see for the red flags for the various complications. Yeah, and we must make sure that we have to look before we leap. We have to try and anticipate complications as well as try and look for common pitfalls. And I'll lastly come to the bane of acetabular surgery, which is heterotopic ossification, because that is what is really going to kill your entire result very well. Having said that, I think I was just going through what are my list of common complications for the whole thing. And they would perhaps, number one, of course, be malreduction and its sequelae. I think all of us keep talking about infection, sciatic nerve injury, and neurological necrosis. I think our first and major issue that we must deal with always is malreduction and its sequelae. Sciatic nerve dysfunction, sometimes if you're lucky, the patient will come to you with a sciatic nerve injury, and so you're rest assured that you can't cause one. Avascular necrosis is going to kill your entirely beautiful reduction and fixation. We will not talk about infection here for the simple reason that each one has his own way of tackling infections and each one has his own number of cases of infection. We'll talk about HO last. So coming to malreduction, sequelae, we'll start with this particular case who's a geologist, a well-read, well-educated person who was operated in somewhere in Dehradun for a fracture of the acetabulum. This was how he came to us about 4 months after the fixation strategy. And you can see that perhaps the reduction is really not up to the mark. I'm not really commenting here on that because I'm sure if when I go back to my earlier cases, I have my own terrible skeletons in my cupboard. And I think as all of us evolve as acetabular surgeons, all of us will learn to analyze our x-rays and our reduction techniques much better and not treat the fracture per se itself only by looking at the CT, but also try and understand the vector which has caused the fracture and try and reverse the vector. And that is what seems to be really important in this particular case. So in this particular case, we had this patient who was a geologist operated somewhere else for a acetabular fracture. He had been fixed up and there was absolutely no reduction of that posterior column at all. So we decided to be foolhardy and go down and fix it all up. And we got a much better reduction. Even if it was 4 months after the injury, we were able to mobilize the fracture. As Dr. Venugopal has said, derotating the fracture is what actually helped us get the fixation in place. And just when we were able to, pat ourselves in the back and tell us that, wow, what a great job I've done. This is such a fantastic result. Everything starts to going wrong all over again. And the head starts subluxating out because probably it had retrospectively looking, had already begun to have changes of avascular necrosis, and the head started resolving. So do remember that a malreduction is not only important from the point of view of that particular patient's present surgery, but it is also going to cause some trouble in the near future, and a malreduction can go completely wrong. Eventually, this patient underwent a total hip replacement with us, and he's doing much better now today. So I think it pays to think. As Dr. Venugopal has told us, it makes a lot of sense to actually think very carefully about how you're going to go about reducing that fracture. And a lot of time should be spent on trying to understand as to what is going to be my plan A for the reduction, plan B for the reduction, plan C for the reduction, and plan Z for the reduction. Because these multiple A and B and C plans are what are going to help you get your reduction in place. Because what you do on day one is what is going to determine what is going to happen to the patient in the future. So as Dr. Venugopal has said, undoubtedly there is a huge case for the use of a transfer. And I find in my practice that we find that most of these fractures are rotated, probably due to the pull of the hamstring and the adductors. So it is rotated downwards and causes an opening of the fracture of the posterior column. It is also rotated inwards. And if we fail to understand this displacement, we will probably fail to get a good reduction. So you may get a apparently good reduction in the posterior column, but the fragment is still rotated unless you put your finger inside the sciatic notch and actually palpate the quadrilateral plate, as he very correctly mentioned. You may have a feeling that you've got a good reduction, but perhaps it is still rotated. So be very, very careful when you do that. You need to understand the rotation happens in 2 or 3 planes, and the best way to get your derotation is to put in a Shanstons in the ischial tuberosity. It has always worked for me, and I'm sure all of us have also seen the same. As we were talking a little while ago, I'm sorry about the repetition of these particular issues, but under contouring, the wall plate helps because it will help prevent the gap opening anteriorly when you're putting a plate in there. And as you said very correctly, over contour the column plate because that will close the gap anteriorly when it comes, especially when you're talking about a transverse fracture like the shown here. One of the problems of acetabular surgery or acetabular surgery is, of course, the sciatic nerve dysfunction. In certain cases, we are lucky to have been presented with a case who already has a sciatic nerve dysfunction, and so you aren't really too worried about it because you are reasonably sure that you will not cause your sciatic nerve dysfunction. Having said that, it is extremely difficult to explain to a patient as to why the sciatic nerve has not got cut and yet it has refused to recover in the first 2 or 3 months. My present experience suggests to me that over a period of time, the sciatic nerve does recover in most of its function. Maybe not all of it, but some of it does recover, and patience is the key to the whole thing. Understanding the sciatic nerve is really important because there are going to be variations in anatomy which all of us should be aware of. 84% of them come anterior to the piriformis. 12% of the peroneal division comes through the piriformis, 3% of the peroneal division comes posterior, and the tibial division comes anterior, and 1% now comes through the piriformis. And being aware of this, because invariably we will all land up cutting the piriformis when we get to the superior lateral portion of the acetabulum, and so we must know the different variations in anatomy. I like to start my talk by saying that we must document preoperatively. Invariably, all of us will land up at some other surgeon's place to do a case, and we will find that the patient has already been undergone an epidural or a spinal when the patient is on the table by the time we reach, and we have absolutely no clue as to whether the patient's sciatic nerve was functioning or it wasn't functioning. So I would very strongly suggest to all of us who are here and who are going to go outside and operate these patients that please ask your anesthetist, do not anesthetize the patient until such time that you've seen the patient yourself. Anticipate certain patients who will have a sciatic nerve dysfunction. We'll come to that a little bit later. I like to keep the knee flexed and the hip extended, and we'll come to this as well. And I like to reduce the femoral head quickly. I think we cannot overemphasize the need for a reduction of the posterior dislocation. I think we cannot overemphasize this. This keeps coming up in different meetings. This keeps on coming up in different talks. But invariably, a large number of us will continue to see CT scans with the head outside. On a recent case, and I don't mean to be rude, but I happened to see one particular patient like this with the head outside still dislocated, and you can see how it was absolutely tenting the sciatic nerve. Here, you can also see that the posterior dislocated head has got some scratches on it as far as the chondral damage is concerned. And these are the patients who you are likely to tell that this is a patient who's going to land up with some arthritis perhaps later on. This is what I like to do. Invariably, what happens is I stand behind the patient when I'm doing a KL approach. I do it in the lateral position, unlike Dr. Lokhande, who likes to do it in the prone, of course. In this case, what happens when I'm standing behind and the patient's and the surgical first assistant is standing in front of the patient, he continues to tend to pull the hip towards him, which causes hip flexion. He also tends to keep the knee extended, which of course means that the sciatic nerve is a tremendous stretch during the surgical procedure. This effectively means that the sciatic nerve is likely to be articularly damaged against your retractor. So one of the tricks that I have developed is, I read somewhere that if you tie the ankle to the thigh, that kind of keeps the thigh and the knee completely flexed all throughout. So if the knee is flexed all throughout your surgical procedure, the chances of damage to the sciatic nerve should be lesser. I have not had a problem per se by this procedure. I have not had a tourniquet kind of an effect because of this bandage. I found it is a useful thing and make sure that whatever happens, the knee is flexed all for the surgery. And this has been one interesting thing that I have kind of learned to pick up. All of us obviously want to avoid a vascular necrosis, and I think all of us are aware that we need to, if we are going to cut the piriformis and not split it, we are going to root about a centimeter away from the femoral attachment so that we are away from the blood supply. As a routine protocol, I do not take the quadratus femoris off from the femur at all. If I have to take it off, I take it off from the ischial tuberosity. That saves me the embarrassment of cutting through the medial circumflex femoral vessel and worrying about a vascular necrosis in the near future. I come to HO, and we call it a tale of two cases, and the case on the right and the case on the left. So that's case 1 and case 2. The case on the right side of case 1 is basically a young guy. He was involved in a road traffic accident, was in coma for 3.5 months, and suddenly one fine day, as he was recovering, one of the physiotherapists noticed that his hip was looking internally rotated and adducted and flexed. An examination showed this kind of a picture, which very fallaciously looks like a hip in place. But if you go down and you see the hip was outside, and you can already see that in 3 months' time, what has happened is that the head has become all abnormal in shape. Case 2 is also a fracture which looks like this. It was a transverse fracture with a significant amount of displacement. Do not miss the sacral-like injury at the back on the right side as well. So HO, of course, is conceptualized as an aberrant tissue repair and is increasingly recognized as a common complication of trauma, surgery, and other systemic or local insults. The spectrum of HO is extremely broad, and you can have a small lesion, you can have a very, very large lesion, which causes a high morbidity. The magnitude of the problem is pretty significant when it comes to acetabular surgery, and almost about 12 to 65%. This is a huge number. 12 to 65% is more, sometimes more than half your entire work is going to get rammed by an acetabular fracture with a heterotopic ossification. Men are more prone to it, and especially all our patients happen to be younger patients. Of course, we are getting a large spurt of geriatric acetabular fractures as well now. But having said that, most of our high injury patients are in the second or third decade. Trauma is a big cause. Identifying the case is a problem. In an early or inflammatory phase, HO represents just localized pain, tenderness, and swelling, which will terribly mimic an infection. On the other hand, later on, when the patient comes back to you 3 months down the line and he's finding that there is gradual maturation of the bone tissue, that the swelling becomes more localized, firm, and restricts motion. And that's when you start wondering what's happening. In the early phases, there is absolutely no ossification, so it is extremely difficult to pick up HO in the early phases. And you want to make sure that you have to be able to differentiate it between infection and HO, early HO. Early lesions can have a floccular irregular opacities, and diagnosis is more than clinical criteria. So keep a high index of suspicion for this particular problem. The classic appearance of mature intramuscular HO is that of a well-developed and well-demarcated radiodense zone with zonal ossification in process. Unlike a neoplastic process, it does not stick to anatomical plane. And you will find that it also attaches to the bone surface. It also encompasses nerves and vessels, and that is where the entire problem starts. On the CT scan, you will find a low density mass in the early stages. And on the MRI, you will find a well-defined mass with a heterogenic signal and looks like a perilesional edema. There may be some fluid levels in the early phase due to hemorrhage. Again, it is difficult to differentiate it from infection. So enhancement after contrast administration can occur central in HO due to vascularity within the lesion. And it can make the differentiation from sarcoma pretty challenging at times. However, of course, you don't really expect to see a sarcoma so quickly after nascent fracture, so that's not a big problem really. There's a Bruker's classification, type 1, type 2, type 3, and type 4. My risk factors peculiar to acetabular fractures are this. If you use an iliofemoral approach, I find the propensity of HO is more. If there's a T-type fracture, I probably feel that this involves a very high energy injury, and so the risk of HO is higher. In associated abdominal chest injuries, and especially in patients who have undergone prolonged ventilation, seems to definitely increase the chances of HO. Presence of multiple operative findings like femoral head damage, sciatic nerve damage, intra-articular bone fragment, which basically suggests a high energy injury, seems to be a high risk factor for HO formation. Delayed internal fixation, I would say this or that, because probably there is some callus formation as we start seeing patients who are 4 weeks into the fracture, and that's definitely a problem. I personally myself don't use bone graft or substitutes in all these patients, so I've not really had a problem with that. So 20% of the clinically relevant HO will result in a decreased range of movement, and that is the whole problem because you're going to have a poor patient outcome score. Prevention, use of radiation, indomethacin, excisional necrotic gluteus minimus, caudal to the superior gluteal vessels, and early physio, and excision of Marginal Impaction. Routinely, people have been giving radiation. Prophylactic doses typically range from 400 to 800 cc and are given another 24 hours preoperatively up to 72 hours post-operatively. But I really have never done that myself, and this is definitely theoretical, and I have absolutely no experience in this particular thing. A single-center randomized trial suggests that 700 given post-operatively was significantly more effective at preventing HO than 400 given post-operatively. I have no idea if any one of you have already using radiation. No, absolutely no experience with this myself personally. Routinely, we have been giving indomethacin historically. It continues to be the gold standard. And it has, however, been given 25 years twice a day for up to 6 weeks after surgery, which suddenly starts mean that it can be a cause for gastric ulcers, decreased platelet function, renal toxicity, and impaired fracture healing because of its effect on inflammation. A very interesting paper by Griffin, Sims, Karunakar, and Seymour, who found that there were no major differences between the combined incidence of moderate and severe HO, Bruker's classification 3 and 4 in the study, when compared with the same incidence for both indomethacin or a placebo. So they did not find any difference in the rates of HO, whether indomethacin was given or it was not given. So the jury is probably still out when it comes to whether you should give it. In my personal experience, in those patients who are high energy patients, I would prefer to be on the side of giving it rather than not giving it. Physical therapy, does it help? It's pretty much unclear. Most of us will make sure that the patient doesn't undergo massages, which probably increases the chances of HO. How it does that, I'm not really sure. Surgical excision, yes. When the mass is mature enough, we can go down and take it out. And I'm going to come to a small little case in this way. This is one of those patients who I showed earlier who had an HO formation, and 3 months into the case, he already had started looking Bruker's type 2 kind of HO formation. The first case which we showed you was this patient with a young dislocated hip who had a head injury. He eventually underwent a total hip replacement because the head was looking really bad. And we were able to reconstruct the femoral, we were able to reconstruct the posterior column using this head fragment that we found and use that as a graft. So I guess the carry home out of this particular message is primarily to recognize patterns of injury prone to HO, counsel patients regarding the same. So if you're doing a transverse fracture, it is worthwhile to tell the patient that, okay, some patients of you, we are not sure who of you, but may require some kind of additional procedure in future because of HO formation. You need to be very careful of the approach and respect for soft tissues. Please be very, very careful when it comes to your dissection, especially when you're taking the gluteus medius and minimus off or putting a sliding plate inside. Of course, the option is to excise it in case range of movement is restricted after 6 months. I thank you for your time and I thank you for your patience.
Thank you, Nirbhay, for this elaborate talk. Sir, I will just complete that case which was started before for this.
May this Guri Parva bring.
This is then fixed with the posterior approach, Cocker-Langenbeck. One plate was used for posterior column and then one plate was for buttressing. These were Jude views. This was final picture.
Thanks.
We generally do post-operative CT scans also of these patients. Just for our learning, not for me. So thank you. I think गीतेचा 12वा अध्याय जसा पूर्ण झाला तसा हा pelvic acetabular posterior wall, posterior columns, whatever things are there in the textbooks, we all discussed everything. कोणी बघू न बघू पण आपण we are well. We are everybody. We had a great journey of posterior wall as well as posterior column fractures. I thank Dr. Manoj also for the great arrangement which he had made. I thank also Dr. Gadegone sir for giving this forum for us to present our some clinical work. Manoj, you can go in for concluding remarks.
Yeah, I think, I thank all of those who have participated today and made this a very big success. We are perfectly on time. We could deliver the all practical take home messages at each talk. And I think this is a different learning method which Dr. Pradeep Kothadiya sir has invented, like to go with a case kind of presentation and then practically elaborating everything on that particular topic till the end. So I thank our MOA President Dr. Gadegone sir, Secretary Dr. Karne. Thanks Dr. Nitin Kimmatkar, Convener for this today's session. I thank Dr. Nirbhay Karandikar as a panelist. And I thank all these 4 faculties, Dr. Venugopal Sambharam, Dr. Milind Joshi, Dr. Vijayanand Lokhande, and Dr. Aditya Kekatpure for their wonderful participation and taking out extra efforts for giving such a excellent work over here. So I thank you again all, and we wish to have, I think, one more session maybe on anterior
wall.
Bola.
This is now a posterior column. You take anterior column next time.
Yes.
And then finally the complicated all those associated factors. 3 sessions we can certainly.
So we'll have a second session because it is actually a very difficult topic. Nicely covered. Our format is very good. So therefore, we will have another session also.
Yes, thank you.
Regarding the anterior wall, and you just create a group. Next time, we'll go ahead with this.
Yes, we'll go ahead.
In month of May. Okay?
Yes, definitely.
Dhanyawad.
Okay. Dhanyawad. Good night, everybody. Thanks a lot. Thanks, Gadegone sir. Thank you. Good night.
Good night, sir. Good night.
Good night.